Step one is screening, especially for those high-risk patients, the ones with resistant hypertension, for instance. Now, here's a key point, maybe even surprising. While that classic picture is hypertension plus low potassium, studies show maybe 40% or so of people with PHA actually have normal potassium levels.
Wow, really? So you can't rely on low potassium being there?
Exactly. Its absence definitely doesn't rule PHA out. The main screening tool is actually looking at the hormones themselves: plasma aldosterone concentration, PAK, and plasma renin activity, PRA. Then you calculate the ratio between them, the PK-PRA ratio, often called the aldosterone-renin ratio, or ARR. A high ARR, say over 20 or 30, especially if the aldosterone level itself, the PRC, is also elevated, maybe over 15 NGDL, that strongly suggests PHA. And remember that renin suppression. We expect to see low renin, a PRA typically less than 1 NGM-LHR. So if that screening ARR comes back high, the next step is confirmatory testing. You need to prove it's truly autonomous production. There are a few ways to do this, like an oral sodium loading test, a saline infusion test, or a fludrocortisone suppression test. The basic idea behind all of them is to challenge the adrenal glands. You give the body a signal that should normally make it turn down aldosterone production.
Like loading up on salt.
Exactly. With the oral sodium loading test, you eat a high-salt diet for a few days. Normally, your aldosterone would drop, but in PHA, it stays high. The glands just ignore the signal. Same idea with the saline infusion test. Giving IV saline should suppress aldosterone, but in PHA, it fails to suppress. The production keeps going. These tests confirm that the aldosterone production is indeed out of control. Okay, so once PHA is confirmed, the final piece of the puzzle is localization. You need to figure out where the excess aldosterone is coming from. Is it one gland or both? Imaging, like adrenal CT or MRI scans, can help. They might show an adenoma, that little benign tumor, or maybe enlarged glands suggesting hyperplasia. And this is really critical for deciding on treatment. The gold standard test is adrenal venous sampling, or AVS.
Adrenal venous sampling sounds invasive.
It is more invasive, yeah. It involves threading catheters into the veins, draining each adrenal gland to directly measure aldosterone levels coming from each side. But it's the most accurate way to tell if the problem is unilateral, like a single adenoma on one side, or bilateral, affecting both glands.